So we will start our MDT with Mrs. Kumar, who is a 55-year-old Indian lady with a past history of cholelithiasis and diabetes, presented with 5 weeks history of right upper quadrant pain. Ultrasound and CT scan reveals cholecystitis, for which she underwent a routine cholecystectomy. I think cholecystectomy in Indian females always get me nervous. So, can we review the post-operative pathology?
Sure, of course. As the surgical specimen actually showed a gallbladder with chronic calculus cholecystitis. However, there is also a foci full differentiated tubular adenocarcinoma invaded the perimuscular connective tissue, but not reaching the serosa yet. The immunohistochemistry of the fragment revealed adenocarcinoma, possibly from the biliary tract. The highest gallbladder cancer incidence rates worldwide were reported for women in Delhi, India, South Karachi in Pakistan, and Quito in Ecuador. Female to male incidence ratios were generally around 3. History for gallstones was the strongest risk factor for gallbladder cancer. Other risk factors are obesity, multiparity, and chronic infections such as Salmonella and Helicobacter pylori. If a gallbladder adenocarcinoma is found incidentally on a cholecystectomy specimen and the patient is being ruled out for metastatic disease, they should undergo an en-bloc hepatic resection plus lymphadenectomy plus minus bile duct excision. The hepatic resection should be performed to obtain clear margins, which usually consist of removing segments 4B and 5. Lymphadenectomy should be performed to clear all lymph nodes in the porta hepatis. This patient has a T2 lesion which has up to 40% chance of harboring lymph node metastases. Thus, this patient needs a definitive surgery.
Dr. Ali, can I ask you a question about one of my patients, Mrs. Fatima?
Yeah, sure, please go ahead.
Well, actually, she's a 60-year-old female, and she had a 6 weeks history of right upper quadrant pain, and she was diagnosed with cholecystitis. She underwent a laparoscopic cholecystectomy, and post-operative pathology revealed that she had inflamed gallbladder, but also, incidentally, they found a T1A gallbladder adenocarcinoma invading the lamina propria. I just wonder, what would you suggest for this?
This is a question for you, Muhammad. If a T1A gallbladder adenocarcinoma is found incidentally with negative margins, then no further surgery may be needed. The long-term survival rates in those patients approaches 100%. However, if a patient is found to have incidentally a T1B or greater staging gallbladder cancer, and if no metastatic disease are found, they should be offered definitive surgery in the form of hepatic resection plus lymphadenectomy plus minus bile duct excision.
Mrs. Jerry, she's a 62-year-old female with a background of viral hepatitis. She presented with a 3 weeks history of right upper quadrant pain and has been diagnosed with a localized intrahepatic cholangiocarcinoma. We did for her staging, including the CT scan and MRIs, and it did not reveal any metastatic disease. She underwent hepatic resection and regional lymphadenectomy of the porta hepatis, and currently we are reviewing the histopathology.
May I ask Dr. Hassan, what kind of hepatitis does she suffer with?
What difference does it make?
Well, I'm sure you know that hepatitis B virus is linked with a higher risk of intrahepatic cholangiocarcinoma compared to hepatitis C virus.
Well, she has hepatitis C virus, and I think hepatitis C virus is actually linked more to intrahepatic cholangiocarcinoma than hepatitis B. But anyway, we'll look into this later. Do we have the histopathology now?
Yes, we do. So the surgical specimen has a moderately differentiated adenocarcinoma consistent with cholangiocarcinoma, surrounded with normal liver tissue. Furthermore, all sampled lymph nodes were negative for cancer. However, the posterior margin is involved with cancer, so this is an R1 resection.
All right, I don't think we are going to do any more surgery, but we can, our colleague, oncologist, do we have anything that we can offer this lady?
Hepatitis C virus confers a higher risk than hepatitis B virus for cholangiocarcinoma. Case control studies from Asia and Western countries have reported hepatitis C infections as a significant risk factor for the development of intrahepatic cholangiocarcinoma. Other risk factors for cholangiocarcinoma includes diabetes, obesity, cirrhosis, non-alcoholic liver disease, alcohol drinking, chronic calculi of the bile duct, and smoking. Ulcerative colitis and inflammatory bowel disease increases the risk of sclerosing cholangitis, which in turn can lead to cholangiocarcinoma. In the post-surgical resection of cholangiocarcinoma, if the margins were found to be positive and further surgery is not possible, then chemoradiation should be offered. Of note, chemotherapy such as 5-FU base or gemcitabine base, or chemotherapy 5-FU base or gemcitabine base followed by 5-FU base chemoradiation, or chemoradiation followed by chemotherapy 5-FU or gemcitabine base would also have been acceptable options for this patient. Postoperative chemoradiation for patients with biliary cancers who have R1 disease has been shown to improve disease-free survival. The role of adjuvant therapy for patients with R0 disease is undefined. However, data from the BILCAB study show that capecitabine may play a role in this situation.
This is acting for clinical education. Like, share, subscribe.
Don't forget to check the resources down below and join us every Thursday 8 p.m. for more videos.